Maternal child nursing represents a broad field of nursing practice. Many women initially enter the healthcare system because of some reproductive system related situation, such as pregnancy, irregular menses, desire for contraception, or an episodic illness such as a vaginal infection. Once women are in the system, however, it is incumbent of healthcare providers to recognize the need for health maintenance and to provide these services as part of a lifelong care for women. Today's lecture, Women's Health Throughout the Reproductive Lifespan, will include topics from Unit 7G. We will review male and female reproductive system, common reproductive issues such as infertility, contraception, and abortion, and we'll review topics on violence and abuse of women. We'll begin with the external structures of the female reproductive system. The external genital organs, or the vulva, as they are collectively referred to, include all the structures that are visible externally from the pubis to the perineum. The mons pubis is a fatty pad that lies over the anterior surface of the symphysis pubis and the labia majora. There are two rounded folds of fatty tissue covered with skin that extend downward and backward from the mons. Both protect the inner vulvar structures. The labia minora are two flat, reddish folds of tissue, visibly only when the labia majora are separated. The clitoris is a small structure composed of erectile tissue with numerous sensory nerve endings. The area between the fourchette, where the labia minora joins underneath the vaginal opening, and the anus is the perineum. This area right here. The perineum is a skin-covered muscular area that covers the pelvic structures. The perineum becomes very important during labor and delivery when that is the area that is stretched or more prone to tearing or rupturing, or the area of an episiotomy to allow for more room for the baby to be able to come out during a vaginal delivery. The internal structures include the vagina, the uterus, fallopian tubes, and ovaries. The vagina extends from the vulva to the uterus and serves as a passageway for menstrual flow, sperm during conception, and as the birth canal. The cervix is the neck of the uterus, which extends down into the vagina. It is made up of mostly fibrous connective tissues and elastic tissue, making it possible for the cervix to stretch during vaginal childbirth. The cervix feels firm, like the end of your nose, with a dimple in the center, which marks the external os. The uterus is a muscular organ shaped like an upside-down pear that sits in the pelvic cavity between the bladder and the rectum. The fundus is the dome-shaped top of the uterus, and it is the site where the fallopian tubes enter the uterus. And you can see that right here, where you have your fundus, you have your fallopian tubes that are connected to the top part of that uterus. The tubes are supported by broad ligaments and range from about 8 to 14 centimeters in length. The tubes provide a passageway between the ovaries and the uterus for the passage of the ovum, which is your egg. The ovaries are almond-shaped or almond-sized endocrine glands that secrete hormones, and once a month until menopause release an ovum or an egg. The two functions of the ovaries are ovulation and production of estrogen, progesterone, and androgen. Now that we've gone over the external and internal structures, we need to now talk about the function of the internal organs. Now, the menstrual cycle is a very complex interplay of events that occur simultaneously in the endometrium, the inside of the uterus, the hypothalamus, and the pituitary glands and ovaries. The hypothalamus and anterior pituitary gland in the female regulate the production of FSH, which is follicle stimulating hormone, and LH, which is your luteinizing hormone. The target tissue for these hormones is the ovary, which produces an ovum and secretes estrogen and progesterone. Menstruation is the periodic uterine bleeding that begins approximately 14 days after ovulation. Menses begins during puberty and continues until menopause. Ovulation is the expulsion of this mature ovum from the ovaries into the fallopian tubes. Oogenesis is the developmental process an immature follicle goes through in order to become a mature ovum and be able to be fertilized. This occurs under the influence of specific hormones, which are estrogen and progesterone, which are produced by the ovaries. These hormones are also important in maintaining a pregnancy, more so in the very beginning of the pregnancy. The uterus is also affected by this during the endometrial phase of the menstrual cycle. Endometrial secretions contain a large amount of glycogen to nourish the embryo until the placenta can take over. The climacteric is a transitional phase during which ovarian function and hormone production start to decline. It spans the years from the onset of premenopausal ovarian decline to the postmenopausal time when symptoms stop. Menopause refers to the last menstrual period and is confirmed with certainty after 1 year of last menses. The average age for menopause is approximately 50 years old. To review the male reproductive system, we must start with the external structures. The external structures includes the foreskin, and it is still removed in most males in the U.S., but if present, it covers the glands. The penis is a vascular shaft that contains the urethra. It is made up of erectile tissue that lengthens and elongates through stasis of blood in the vessels. The gland is the tip of the penis. The scrotum is a muscle tissue that lowers the testes to control their temperature and allow for the best possible conditions for sperm production. The internal organs, the testes, prostate gland, and seminal vesicles all work together to produce semen. The tubes of the epididymis, the vas deferens, and the urethra all work to transport the sperm and the semen. The functions of the internal organs. The spermatogenesis is the production of sperm that takes place in the testes. The spermatozoa move through the tubulars of the epididymis where they develop motility and fertility. Finally, they are stored in the reservoir of the epididymis until needed for ejaculation. Secretion production occurs in the prostate and seminal glands. They create a milky white fluid that nourishes the spermatozoa during and after ejaculation. Age-related changes occurs at different times in the male's life. Puberty causes a great increase in serum testosterone. This will stimulate elongation and thickening of the penile shaft and sperm production. By middle age, sperm count and motility begin to decrease. And there is some debate about whether andropause, the male menopause, is a real condition. But those of us who live with middle-aged men really know the truth about that one. Then finally, the external organs begin to atrophy in the elderly years of the male. We will begin to discuss a very common reproductive issue, infertility. Infertility is defined as the inability to conceive a child after 1 year of regular sexual intercourse, unprotected by any contraception. There are many factors in both men and women that contribute to normal fertility. A normal developed reproductive tract in both the male and the female partner is essential in order to be able to conceive. Normal functioning of an intact hypothalamic pituitary gonadal axis supports gametogenesis and the formation of sperm and ova. This is essential for the ability to have fertilization take place. After fertilization, the fertilized ovum must be able to travel down the patent fallopian tube to be able to go to the uterus and then implant in a hormone-prepared endometrium. Any alteration in one or more of these structures, functions, or processes will result in some degree of impaired fertility. When discussing the male fertility factors, we can start with sperm being very highly subjective to malformation. At least 50% of the sperm must have normal form in order to achieve optimal fertility. They also need to have normal patterns of movement. Drug use, hot tubs, tight clothing, cigarette smoking, or scrotal trauma can all cause malformation or a loss of motility. Testosterone is the primary player responsible for libido and sperm production. Erection is a physical necessity and has to be maintained long enough for ejaculation near the cervix to occur. And the ejaculate has to have at least 20 million of the sperm in order to be able to get the job done, in order to be considered fertile. When discussing female fertility factors, we must begin with ovarian factors. And if you have a non-ovulating ovary or ovaries that are not producing mature ovum and going through the process of ovulation, you will not be able to also conceive because you don't have the regular ovulatory cycles that need to occur. Uterine, tubal, or peritoneal factors will include issues with structure as well as hormonal factors having to do with the lack of progesterone or the lack of a viable or patent fallopian tube. Also, you can have factors that include structural abnormalities that can cause decrease in fertility. And then you have other factors which are just unknown. If everything seems to be working properly, and then there's just something that we're not picking up or that we just can't pinpoint as a factor of infertility. Infertility is a serious medical concern that affects quality of life and is a problem for approximately 10 to 15% of reproductive age couples. Normally, a fertile couple has approximately a 20% chance of conception in each ovulatory cycle. Although male infertility contributes to more than half of all causes, infertility remains a woman's social burden. As we begin to talk about infertility, we must begin with assessment. Primary infertility applies to a woman who has never been pregnant. Secondary infertility applies to a woman who has been pregnant before but is now having difficulty or the inability to conceive again. The nurse assists in the assessment by obtaining data relevant to fertility through interview and physical examination. Some of the data needed to investigate impaired fertility are of a sensitive, personal nature. Obtaining this data may be viewed as an invasion of privacy. A high level of motivation is needed to endure the investigation. We must also consider cultural considerations. Cross-culturally, the expectation for couples to reproduce is an accepted norm, and the inability to conceive may be considered a violation of this cultural norm. Religion often influences cultural factors, and by this reason may also be considered when pursuing treatment for infertility. Etiology and risk factors that are considered during our assessment are going to include reproduction that requires the interaction of a female and a male reproductive tracts, which involves 1. The release of a normal pre-ovulatory oocyte, 2. The production of adequate spermatozoa, 3. The normal transport of a gametes to the ampullary portion of the fallopian tube where fertilization takes place, and 4. The subsequent transport of the cleaving embryo into the endometrial cavity for implantation and development. Risk factors for women are going to include overweight or underweight can disrupt hormone function, hormonal imbalances leading to irregular ovulation, uterine fibroids, tubal blockages, cervical stenosis, reduced oocyte quality, chromosomal abnormalities, congenital anomalies of the uterus, immune system disorders, chronic illnesses such as diabetes, thyroid disease, or asthma, and STIs. Risk factors for men can include exposure to toxic substances like lead, mercury, X-rays, or chemotherapy, cigarette or marijuana smoke, heavy alcohol consumption, use of prescription drugs for ulcers or psoriasis, exposure of the genitals to high temperatures such as hot tubs or saunas, hernia repair, and obesity is also associated with decreased sperm quality. Interventions are going to include treatment of infertility that requires considerable physical, emotional, and financial investment over an extended period of time. For women, investigation of impaired fertility will begin for women with a complete history and physical examination. The basic infertility survey of the woman involves evaluation of the cervix, uterus, tubes, and peritoneum, detection of ovulation, assessment of immunologic compatibility, and evaluation of psychogenic factors. Basal body temperature, as described before, is an evaluation of the woman's basal body temperature. And elevation occurs in response to progesterone and documents ovulation. Serum hormone testing includes blood tests that check adequacy of the progesterone and estrogen production from the ovaries. Endometrial biopsy is done during day 21 to 27 of the menstrual cycle, and it involves suctioning of the inner lining of the uterus in order to detect decreased progesterone levels. An HSG, which is a histosalpingogram, is done during days 7 through 10 of the cycle. And a contrast dye is injected into the uterus, and if it spills from the tubes, it confirms patency of fallopian tubes. The postcoital exam is scheduled 1 to 2 days before ovulation. The couple has intercourse 8 to 12 hours before the exam. Then they come into the office, and a 10 cc syringe with a catheter attached is used to collect the vaginal secretions for analysis of sperm motility and semen versus mucus interaction. Please remember that the majority of tests performed on the woman are either painful, embarrassing, or both. Your best nursing support will definitely be utilized by the infertility patient. For males, the basic test for male infertility is the semen analysis. A complete analysis studies the effects of cervical mucus on sperm, forward motility, and survival, and evaluations of the sperm's ability to penetrate on ovum provide basic information. Seminal deficiency may be attributed to one or more of the variety of factors. Both physical and environmental hazards, such as drug and alcohol use, can affect sperm and its ability to penetrate the ovum. The attitude, sensitivity, and caring nature of those who are involved in the assessment and treatment of infertility lay the foundation for the patient's ability to cope with the many tests and treatments they must undergo. Many infertile couples are not prepared for the emotional roller coaster of grief and loss that accompanies infertility treatments. Financial concerns and coping as a couple are two major areas of stress when treatment is undertaken. During the course of what may be months or even years of infertility care, it is essential to develop a holistic approach to nursing care. Stress management and anxiety reduction need to be addressed, and referral to a peer support group such as Resolve might be in order. A nationwide network of chapters dedicated to providing education, advocacy, and support for men and women facing infertility. Resolve helps to provide a helpline, medical referral services, and a member to member contact system for couples suffering through infertility. So, as we discuss interventions, treatment of infertility require considerable physical, emotional, and financial investment over an extended period of time. For women, investigation of impaired fertility will begin with a complete history and physical exam on the patient. Basic fertility survey is going to involve evaluation of their cervix, their uterus, their fallopian tubes, their peritoneum, as well as detection of when they ovulate, an assessment of any immunologic compatibilities, and evaluation of any psychogenic factors as well. Serum hormone testing will include blood tests to check the adequacy of those essential hormones such as progesterone, estrogen productions from the ovaries. They might also do an endometrial biopsy, which is usually done around day 21 to 27 of the menstrual cycle. And this involves suctioning the inner lining of the uterus to detect any decrease in progesterone levels. The one main test that's also done is called a histosalpingogram or an HSG. This is done during days 7 through 10 of the cycle, and a contrast dye is injected into the uterus. And if it spills from the tubes, like if it goes through and into the uterus, then it confirms that the fallopian tubes are patent. And then they know that it's not any clogged tubes that are causing the infertility. The postcoital exam is another exam that's done. This is usually scheduled 1 to 2 days before ovulation. The couple is asked to have intercourse about 8 to 12 hours before the exam. Then they come into the office, and a 10 cc syringe with a catheter attached is used to collect the vaginal secretions, which they analyze for sperm mobility, for sperm motility, that they're able to be good swimmers, and for semen and mucus interaction. Please remember that the majority of these tests performed on the woman are either painful, embarrassing, or both, and your best nursing support will definitely be utilized by the infertility patient. For males, the best test for a male for infertility would be a semen analysis. And now this complete analysis will study the effects of any cervical mucus on the sperm and how they swim in that cervical mucus. It will determine how well they survive and how well they're able to penetrate the ovum as well. So that basic semen analysis is going to really tell us a lot of information. Seminal deficiency may also be attributed to one or more of a variety of factors. So we might also be able to kind of determine ways or why there may not be enough seminal fluid. We do both physical and environmental hazard evaluation as well. So things like drug use or alcohol use, which can affect fertility and sperm production, is also evaluated as well. So again, the attitude, the sensitivity, and caring nature of those who are involved in the assessment and treatment of infertility lay the foundation for the patient's ability to cope with the many tests and the treatments that they must undergo. So many infertile couples are not really prepared for the emotional roller coaster of grief and loss that will accompany infertility treatments. Financial concerns, as well as coping mechanisms
that the couple has or doesn't or may lack are two major areas of stress when treatment is undertaken. So we really need to be conscious of these different how these couples are tolerating these course of treatments and testing that must be done, as well as these treatments may last the course of months to even years. And so we also need to help them to develop a holistic approach to care. And as nurses, we need to be able to instill the holistic approach of nursing care as well. Stress management and anxiety reduction need to be addressed, and referrals to peer support groups such as Resolve might be in order. Resolve is a nationwide network of chapters dedicated to providing education, advocacy, and support for men and women facing infertility, and they provide a helpline, medical referral service, and a member-to-member contact system as well. Okay, so before we show the following video, it does go over treatment methods that are common in infertility care and infertility treatment for couples today. Each of the methods that you'll see on the video are methods that have been used successfully. And as far as testing purposes, you just need to realize that there are specific methods and the different names of the methods, but you do not need to know the specifics of each method. We're not going to test you on the specific methods and how each one is done. We're just going to test you on your knowledge that there are certain methods that are used and what are possibly some, and these are possibly some. So your book does go over in a lot more detail each of these methods, and like I said, you're not going to be responsible for knowing the details of each method, just the fact that these specific methods have been used and in the past with major success.
Non-pregnant women of reproductive age typically have menstrual cycles that last approximately 1 month. Every month, an ovarian follicle containing an ovum, an egg, grows under the influence of the body's hormones. At the midpoint of the cycle, ovulation occurs, which is also regulated by hormones. The ovum, which is ready to be fertilized from this point on, is taken up by the fimbria of the fallopian tubes, which act as conduits to the uterus, where it awaits the arrival of viable sperm. The desire to have children is a natural human instinct, but it cannot always be fulfilled. The causes of unwanted childlessness are numerous, as are the options for treating them. With intrauterine insemination, the timing of sperm delivery is tightly controlled using a sperm sample provided by the male partner at the time of ovulation, or by using a previously frozen sample. In the laboratory, the ejaculate is often passed through a special filter system in a conical tube, slowly centrifuged, and then washed. Only active sperm cells are collected in this way. Other parts of the ejaculate are discarded. Using a syringe and a thin catheter, the prepared sperm cells are directly introduced into the cavity of the uterus or womb beyond the cervix, the mouth of the womb. Once deposited there, the sperm immediately make their own way towards the awaiting egg in the fallopian tube. The objective here is to minimize the distance to the egg awaiting fertilization for as many fit sperm cells as possible. As a result of the earlier preparation, the sperm cells are more motile and the heads of the spermatozoa have undergone a maturational process that prepares them for fertilization. With in vitro fertilization, which is sometimes known as the test tube baby technique, the ovaries are first stimulated with hormones so that they produce several ovarian follicles. Before physical ovulation takes place, but after oocyte maturation is initiated by the administration of a further hormone, the follicles are aspirated. This means that the follicular liquid and the egg it contains are extracted with a needle. This is performed under sedation in a short outpatient procedure, with the doctor using transvaginal ultrasound to check the proceedings. In the lab, the eggs collected in this way are brought into contact with sperm cells which have already been cleaned and concentrated. The eggs and sperm cells remain in an incubator set at 37 degrees centigrade for 24 hours so that natural fertilization can take place. During this process, one of the many sperm cells will find its way into each egg. Once fertilization has happened, at least one living embryo that has already divided itself into 4 to 8 cells should have developed. 1 to a few days later, one or more embryos are transferred by means of a thin inflexible catheter to the cavity of the uterus, where the embryo can embed quite naturally into the uterine mucosate lining of the womb. A further development of in vitro fertilization is what is known as intracytoplasmic sperm injection, or ICSI for short. The ovaries are first stimulated with hormones to allow several ovarian follicles to mature. The eggs are then removed by aspiration. This takes place under sedation during a short outpatient procedure. Fertilization takes place by injecting an individual sperm cell into one or more of the collected eggs. For this purpose, the egg is held in a holding pipette and one sperm cell is injected under the microscope directly into the ovum by means of a very fine pipette. After about 24 hours, the eggs are checked for signs of fertilization. After a further 24 hours, the embryo, undergoing cell division all the while, can be transferred to the cavity of the uterus by means of a thin catheter and left to embed itself into the uterine mucosa, just as in natural pregnancy. All these methods of assisted reproduction offer couples a good chance of bringing a healthy baby into the world. A physician consultation and thorough examination are prerequisites for establishing the most appropriate treatment with the highest chance of success for each individual patient. Because female fertility decreases after the age of 35, couples with an unfulfilled wish to have children should not delay seeking appropriate medical advice.
Okay, so now we're going to start our discussion regarding contraception. And contraception is considered, or family planning as it's also known, as the conscious decision on when to conceive or avoid pregnancy throughout the reproductive years. The actual decision to use a contraceptive could be made either jointly as a couple or individually by the man or the woman. In an era when many women wish to delay pregnancy and to avoid STIs, choices are very difficult. Numerous methods of contraception are available today, and many more will be offered in the near future. And as you can see in our slide here, there are 4 major categories of contraception or contraceptives. You have your behavioral methods, and your behavioral methods are going to be methods that require both either the male or the female to change their behavior in some form or other. So it's going to require them to do some work themselves. These methods are usually the methods that are non-hormonal or non-mechanical. These are methods usually that are require human control or human self-control. Their second method is the barrier method. And this method is going to include methods that are going to apply or produce a barrier between the sperm and the ovum. So it's not going to allow sperm to get anywhere near or close to the ovum, and so pregnancy cannot happen. The third category is going to be your hormonal category, and this is the category that most patients today are familiar with. This is the category that has the most abundant of different options. And these are the this is the category that is going to include all of the methods that are hormone related, meaning that they're going to change the patient's hormone combination or hormone characteristics in order to prevent pregnancy. And then your last category are your permanent methods. And those are the methods that will be considered to be permanent methods of contraception, meaning that the patient, once they get these methods, will not be able to conceive again. And then these methods would make the patient completely sterile. So these methods are considered permanent. So in summary, we are going to go through each of these categories with the methods inside. With the methods that are in each of the categories. But really what I wanted to make sure that in the ideal contraception method for any woman or for many women would have the following characteristics. And you want the methods to be easy to use, safe, effective, have minimal side effects. They feel more natural. There could be a non-hormonal method, and they're easily reversible if the patient wanted them to be. And that ideally is what every woman is looking for in a contraceptive method. So let's go and start going through each of these methods separately. Okay, so we're going to start with the barrier methods. And the barrier methods consist of abstinence, fertility awareness methods, coitus interruptus, and lactational amenorrhea. So these methods are safe and situational approaches to birth control. The difficult part is that the client has to exercise a very high degree of self-awareness and self-control to achieve its effectiveness. So when we start with abstinence, abstinence is the act of avoiding intercourse completely. So the advantage of this method is that it's safe, of course, it's free, and it's readily available to everyone. And it's also 100% effective, which is the only one that's actually 100% effective. But it does require a bit of self-control on the part of both partners. Now, family fertility awareness methods, or FAMs, as they're also known as, depend on identifying the beginning and the end of the fertile period of the menstrual cycle. So there's 3 phases that are identified. You have the infertile phase, which is before ovulation. Then you have your fertile phase, which is about 5 to 7 days around the middle of the cycle, including several days before, during, and the day of ovulation. And the infertile phase, again, which is after ovulation. The advantages of these methods include that they're low to no cost at all. They don't use any chemical or hormonal interference. And they lack of alteration in the menses, which some women would prefer without taking hormonal contraceptives, which kind of can play havoc with your hormones. These methods don't do that. It is also acceptable for couples who have religious prohibitions against other methods like hormonal methods or IUDs or implantables. So this will also be acceptable for those couples practicing under religious considerations. It is also difficult, if not impossible, to do if the woman does not have a regular menstrual cycle. And this is where the method gets a little tricky. There are several different variations to the family fertility awareness methods. The most common one is the calendar method. And this method is practiced based on the number of days in each cycle, counting from the first day of the last menstrual period or from the first day of that first menstrual period, and so forth. So you count day 1 as your first day of your period. It uses a formula to determine the fertile period. So using this formula, if you subtract 18 days from the length of the shortest cycle and subtract 11 days from the length of the longest cycle, then you can pretty much determine the fertile period. But again, remember, this is all contingent on the fact that a woman has a normal menstrual cycle. So that means that every month she gets her period on day 28 or on day 30 every month. And so in order for this method to be effective. So for example, if a woman has a very regular period, let's say every 28 days, then the formula would indicate that her fertile period should be from about day 10 to day 17, because ovulation will occur about day 14, and that usually gives you plus or minus 2 days. So that is the calendar method, and lots of women use this method in different variations. So they might do it just by knowing that their periods are very regular. There's beads also that are available that they can use to help them with their fertile periods. So they use like this little bead with this little rubber band that'll kind of put them around around when their days are fertile, and it'll turn red, or when they're fertile days, or black when they're not fertile. So those kind of things. So there's different methods to be able to different ways to be able to keep up with this method, the calendar method. Now, we do add certain things to make the calendar method much more effective, like taking their basal body temperature or using a symptothermal method, which you kind of add your temperature and the cervical mucuses that are normally released during ovulation, and that cervical mucus change that occurs during that ovulation period helps the woman to kind of know that she is ovulating. And so sometimes we can add all of those together, and we can get a much more accurate picture of when they're going to be fertile and when they're not fertile. For testing purposes, again, your method that I really would like you to concentrate on is the calendar method. All the other methods are just additional to the calendar method, and those you probably just need to kind of peruse over and kind of look at and know about them, but you're not required to know the specifics of each of those ones. So the next method that is under the barrier category is coitus interruptus. And this one we all know as withdrawal or pulling out. It does involve the male pulling out and ejaculating far away from the female genitalia. And like I said, it has to be far away, not on the thigh, not on the stomach, not anywhere near where they can possibly swim their way up to where they're supposed to go. Although the effectiveness of coitus interruptus does depend mostly on the man's disciplined capabilities to consistently ignore the powerful urge to continue thrusting, it has some advantages over using no method at all. So this method is immediately available. It doesn't cost anything. It involves no hormone or chemical alterations. Coitus interruptus does not adequately protect against STIs or HIV infection because, again, they're not using anything for that protection. It is only typically about 80% effective due to pre-ejaculatory fluid, which can release also some sperm as well. So that is your one of your main reasons why it's not very effective at all. And then your last method in this category is your lactation amenorrhea method, and this is effective temporarily because while moms are breastfeeding, it does rely on the physiologic changes that occur with breastfeeding. Continuous breastfeeding usually can postpone ovulation and thus preventing pregnancy. It is not always very accurate, and it's not always very effective as well. Breastfeeding stimulates the hormone prolactin, which is necessary for milk production, and it also inhibits the release of another hormone, gonadotrophin, which is what is necessary for ovulation. It could usually only effective for about 6 months, and in those 6 months, it's only really effective if the woman has not had a period since the day she gave birth, and if the infant is younger than 6 months of age, or like I said, for the first 6 months. Reason being is because if the woman, if the baby is bigger, once the baby gets bigger, then they're usually introducing more than just breast milk, and they're introducing some form of solid food, and so her milk production will start to decrease. And if that happens, then the levels of hormones also start to decrease, and she's more likely to get a period or have ovulation. She has to be breastfeeding for at least 6 times a day on both breasts, and her baby needs to be breastfeeding on demand at least every 4 hours. She can't be alternating or substituting breast milk for any other solid food. So even if she's giving solid foods and still breastfeeding, she's not breastfeeding enough to keep those hormones elevated. And nighttime feedings are provided at least every 6 hours. So she's got to be even breastfeeding at least every 6 hours during the night as well. And so this pretty much wraps up our barrier methods as well. Our behavioral methods as well. I kept calling them barrier methods today. It's behavioral methods that we were just discussing. Okay, so now we're going to discuss the barrier methods. These category consists of methods that include condoms, diaphragm, cervical cap, and the contraceptive sponge. And now, barrier methods, in addition to providing a physical or a chemical barrier to block the sperm from entering the cervix, they also have gained popularity because of their additional protective measures against STIs and especially HIV. Spermicides, work by reducing the sperm's mobility as the chemical attacks the sperm and prevents them from reaching the cervical os. Naloxone 9 is the most commonly used spermicidal chemical in the U.S., and it comes in several forms. A fresh application in each is needed for each sexual act, and each application is effective no longer than 1 hour. Condoms are another method in this category, and the male condoms we all are familiar with. They're made of latex, rubber, polyurethane, or natural membranes. During condom use, couples may experience condom breakage or slippage in about 3 to 5% of the time. In addition to providing the physical barrier for sperm, non-spermicidal latex condoms also provide a barrier for STIs and HIV. Latex condoms should not be used with oil-based lubricants as they will break down, and should only be used with water-based or silicone lubricants. Because of the growing number of people with latex allergies, condom manufacturers have begun using polyurethane, which is thinner and stronger than latex. Research is now being conducted to determine the effectiveness of these condoms against STIs and HIV. And we've gotten some pretty good results, but we still haven't had definitive results with polyurethane condoms as of yet. Those results haven't come in yet from the research that is being done. There used to be a female condom that was developed. It is a lubricated vaginal sheath that covers the cervix. It does totally line the vagina and partially covers the perineum. The female condom is available in one size fits all. It is intended for single use only, and it is sold over the counter. It was kind of popular at one point in the beginning when they were first introduced to the American public, but then they kind of fell out of fashion. They were kind of loud, a little uncomfortable, and not very spontaneous. Male condoms should not be used at the same time because it does increase the risk of tearing either condom. It is about 95% effective in theory. However, it is only 79% effective in typical use. The most important thing to tell the client is that after intercourse, the condom should be removed before the patient actually stands up by twisting the outer ring while gently pulling the device out, because you don't want the sperm to fall out into the vagina, because that of course defeats the purpose. Another method in this category is your diaphragm. Diaphragm is a shallow dome-shaped latex or silicone device with a flexible rim that covers the cervix. The optimal contraceptive method, diaphragm, should be used with a spermicide. So it needs to be used along with a spermicide to give it its optimal effectiveness. The device should be inspected before every use. It needs to be replaced after every 2 years, and may need to be refitted if there is a more than a 20% weight fluctuation. After any abdominal or pelvic surgery, and after every pregnancy. Diaphragms do need to be fitted in order to be completely effective, because the direct size needs to be determined. It can be inserted up to 4 hours before sex and has to stay in place for at least 6 hours after. If there's another sexual act within those 6 hours, another applicator full of spermicide should be inserted without removing the diaphragm, which will help its effectiveness as well. The device must be removed at least once every 24 hours to prevent the possibility of toxic shock syndrome. Now, the cervical cap and the contraceptive sponge are kind of both takeoffs of the diaphragm. So the cervical cap, or the FemCap, is the only cervical cap device currently available in the US, and it does come in 3 separate sizes. The cervical cap will fit snugly around the base of the cervix, and it does work the same way that the diaphragm does. Some of the differences are that the cervical cap can be inserted hours before intercourse without a need for additional spermicide later. No additional spermicide is required if there are repeated acts of intercourse when the cap is in use, and the cap requires less spermicide than the diaphragm when it's initially inserted. The problem with the cervical cap is that it is just fitted to go around the cervix. So there is a much higher possibility of human error when inserting it, because it needs to fit right over the cervix. So if the patient has difficulty inserting it and misplaces it, then it's not going to be effective. It's not going to be placed in the right spot to cover the entire cervix and that opening, so the sperm can still get in. The contraceptive sponge, again, like I said, is kind of like a takeoff of the diaphragm. It's called the Today sponge. It hasn't been available in the US since 1995. It did come back into play in 2009. It did receive reapproval from the FDA, and it's now again back on the market. The reason why it was taken off the market was because they had some logistical issues with it, with the sponge moving, not being, having difficulty removing, those kind of things. So that is what caused it to be taken off the market for a while. It is a small, round polyurethane sponge that contains the Noxil 9 spermicide. It is available over the counter as a one-size-fits-all type of design to fit over the cervix. The side that is placed next to the cervix is more concave in shape for a better fit, and the opposite side has a little loop on it to be able to use for removal. The sponge must be moistened with water before inserted, which will provide the protection for up to 24 hours and for repeated instances, and should also be left in place for at least 6 hours after the last act of intercourse. It is much less effective than several other methods, and it does not protect the patient against any STIs. Okay, so we've reached the hormonal methods, and that is the largest of the 4 categories. There are more than 30 different contraception formulations that are available in the US today. Formulations that include combined estrogen and progestin medications and progestin-only agents. They are administered either orally, transdermally, vaginally, by implantation, or by injection, as well as intrauterine. We'll start with your oral contraception. And your oral contraceptive pills will suppress the action of the hypothalamus and the anterior pituitary, leading to an inappropriate secretion of FSH and LH. And if you remember from the beginning of this lecture, your FSH and your LH are those hormones that stimulate the maturation of the follicles in order to produce a mature ovum. And when you have decreased or inappropriate amounts of these hormones, the follicles do not mature and ovulation is inhibited. Maturation of the endometrium is also altered, making it a very less favorable site for implantation. So from 1 to 4 days after that last oral contraceptive pill is taken, the endometrium will start to slough and bleed as a result of a hormone withdrawal. So they're not bleeding really because they're getting a true period, but because the levels of hormones have been now decreased because they're not taking in those last 7 days any hormone, they're just taking placebo or vitamins, then the patient will have a withdrawal bleed. This bleeding usually is much less profuse than the normal menses, and it may only last anywhere between 2 and 3 days, if not less. Women must be screened for medical conditions that will preclude the use of oral contraceptives, such as a history of thromboembolic disorders, CVAs or CAD, breast cancer, or any other estrogen-related tumors are going to be contraindicated. Of course, smokers over the age of 35 years old as well are going to be precluded. It should be stressed that it is important for the client to be aware of what side effects the oral contraceptive pills are acceptable and which ones she needs to be able to inform her doctor about. Okay, so in order to do this, in order for the patient to know what side effects she should be worrying about, we've created a mnemonic, and the mnemonic stands for ACHES, and that is ACHES. And this mnemonic can help women remember the early warning signs that necessitate a return to the healthcare provider. So this is what's going to tell her, you know what, I'm feeling one of these symptoms and I need to call my doctor. In the box of 4.6 in your book on page 119 of your ebook, it is also goes over ACHES there as well. And we'll go through each letter of the mnemonic so you can understand what it means. So your A stands for any abdominal pain, which may indicate liver or gallbladder problems. Your C is going to be chest pain or shortness of breath, which may indicate a pulmonary embolism. H is for headaches, which may indicate hypertension or an impending stroke. E is for eye problems, which may indicate, again, hypertension or some type of attack or microvascular deterioration. And then S is going to be for severe leg pain, which may indicate a thromboembolic event or a DVT. Also, clients need to be informed about what to do if the pills are missed and when to use a backup method. Also in your book on page 150, there is a chart which does describe what to do for missed pills. And just to make sure that you do go over that in your book, that is something that will be testable material, is knowing what to do if you miss a pill or not. So, like I said, all hormonal methods are going to have the same side effects. All hormonal methods are going to have the same contraindications. So when we discuss each of these different types of hormonal methods, We're just discussing the differences in the method, in the application of the method, not the method itself. So the transdermal patches, they're called Ortho Evra, and this is a contraceptive transdermal patch which delivers the same hormones as does the pills in a steady release state. It's changed once a week for 3 weeks, and then it's left off for 1 week. And that week that it's off is when she will get her period. So it works almost the same way as the pills. You do 3 weeks on, 1 week off. That's when you get your menses, and it has the same potential complications and side effects as the pills do. The vaginal ring is known as the NuvaRing, and this is a flexible ring worn in the vagina, which delivers continuous levels of both estrogen and progesterone. The ring is worn for 3 weeks, followed by a week off. The same thing, 3 weeks on, 1 week off. The ring is inserted and it rests on the very top of the vagina. It gives a better control and has less systemic effects than the pill or the patch because it's basically more local. And so it kind of changes, those hormones are more absorbed through the mucous membranes of the vagina. And so they're closer to the organs of like your estrogen, your ovaries and your uterus. And so it doesn't need to go into the bloodstream as much as the other two methods. The next method is your injectable contraception. And then your injectable is Depo-Provera. It's also, generic name is Depot medroxy progesterone acetate. So it's Depot medroxyl progesterone acetate. It is 150 milligram dose. It's given intramuscularly initially during the first 5 days of the menstrual cycle, and then it's administered every 11 to 13 weeks thereafter. The advantages of this method is that it is very comparable to oral contraceptive pills in that it only requires to be given 4 times a year. However, the problem with the Depo-Provera, or not a problem, but one of the disadvantages, is that it can cause erratic bleeding for many women because it is only progesterone. So unlike the other methods that we've discussed so far that have been a combination of estrogen and progesterone, with Depo-Provera, as it's known, it only has progesterone. So because it only has the progesterone, which only affects the endometrial lining, it can have this erratic bleeding. And sometimes this erratic bleeding can be very uncomfortable or intolerable for lots of women because it's so irregular. It can stop. They can bleed continuously for weeks. They could not have any periods at all. And so it's very erratic and hard to predict. A nursing consideration of this method is to never massage after injecting the medication, as it can alter its effect. Also, there may be an increased need for calcium supplements, since Depo-Provera can have, one of its adverse effects is that has an effect on the calcium supply and affects bone growth. So many women who are younger, your young population, your young teenagers, they will give this method along with calcium supplements to make sure that their growth isn't stunted. We've also kind of limit the amount of time that young women can use this method. We try not to have them use this method for longer than 2 years at a time, just because of the fact that it can stunt their growth significantly. So we try to limit that the amount of time that they're on it as well. Another method is your implantable contraceptive. The implant is a subdermal time release method. It delivers synthetic progestin that inhibits ovulation. So again, this is just a progestin only implant, just like your Depo-Provera. But once it's placed, it delivers 3 years worth of continuous, highly effective contraception. Implanon is its brand name. This is a single rod implant. It's currently available in the US. It does work the same way as its predecessor, which is the Norplant. Norplant was 5 rods. Your Implanon is 1 rod. It's a celastic capsule the size of a matchstick. It contains progesterone, which provides up to 3 hours of contraception. I'm sorry, it's 3 years of contraception, and it's injected underneath the skin of the upper arm. So it provides up to 3 years of contraception with the Implanon. Again, because it is only a progestin only, what would you expect with a progestin only method is erratic bleeding. Exactly. And so erratic bleeding can be a reason why this patient may not want to take it because of the bleeding. And then another method is your intrauterine contraception. Intrauterine contraceptives are classified as either hormonal or non-hormonal. They both types do prevent pregnancy via inhibition of sperm mobility and sperm viability. And they do change the speed of transport of the ovum into the fallopian tubes. So the IUD is a small T-shaped device with bendable arms for insertion through the cervix. Once inserted against the uterine fundus, the arms open up near the fallopian tubes to maintain the position and to adversely affect the sperm motility and irritate the lining of the uterus. So the IUD is not, there's 2 types of IUDs. The non-hormonal is called the copper T. The copper T has a copper wrapped on the longer end of the T, not the phalanges, not the top part. And this method is good for 10 years. The copper T is your IUD that is non-hormonal. So what it does is that copper, as it's slowly released in the uterus, it provides a very toxic environment for that uterus. So your patient will still have or can still have fertilization. However, once that fertilized egg tries to implant into the uterus, it can't. The environment is toxic. It's not able to nourish the fertilized egg, and so it just falls through, and then the patient will get a period. So with the copper IUD, the big difference is that it will prevent implantation as compared to other methods that hormonal methods that prevent ovulation and thus preventing fertilization at all. But your copper prevents implantation and not ovulation. So your patient can technically still get a fertilized egg and pass through and try to implant into the uterus, but the environment is so toxic that it won't be able to implant. The other hormonal-based type is Mirena, and that Mirena is now filled with a hormone. And again, it is only progesterone, and that hormone is good for 5 years. And that hormone is released slowly into the uterus to prevent the lining from being able to be established properly. That hormone's released, that elevation of progesterone kind of triggers the ovaries to say, hey, I must be pregnant because my progesterone levels are so high. So it does kind of like fake out their ovaries to thinking that they're pregnant, so they don't release any more eggs. But it does provide 5 years of protection for the patient. Again, because of the progesterone only component, it can have erratic bleeding as well. The two parts of this intrauterine methods is that neither one of those two methods will provide protection against STIs, and both of those methods can have an increased risk for pelvic inflammatory disease caused by an STI because of the strings that are left hanging into the vagina. So these little strings from where the IUD is actually, so that the patient can know that it's still in place. It has these little strings that are kind of left into the vagina, very small, but any type of sexually transmitted infection that kind of sits in the vagina will usually like to migrate upward. And in this migration, we'll usually use the strings as a rope, to say the least, and they will climb up and get into the uterus rather quicker than if the IUD was not there. So that's why IUDs do have a higher risk for STI and for PID. And they have no protection against your HIV or STIs at all. And then lastly, having to do with hormones is your emergency contraception. This is available in over 100 countries now, and in about 1/3 of those countries, it is available without a prescription. Only one product is approved in the US as emergency contraception. That is Plan B. Plan B does contain 2 high doses of oral progesterone, which is taken about 12 hours apart. The emergency contraceptive should be taken as soon as possible, but within 72 hours of unprotected intercourse to prevent any type of unintended pregnancy. Other options for emergency contraception are regular oral contraceptive pills given in an alternate schedule, or putting in an IUD. Those would be other methods, other ways that we could provide emergency contraception. But as a product, emergency contraception is only Plan B, and it does have to be taken within 72 hours, and it's 2 pills taken 12 hours apart. And like I said, that is our largest category of our contraceptive methods that we have available. Okay, so our last category is the permanent method category, and this includes the sterilization process. So sterilization refers to a surgical procedure that is intended to render a person infertile. So it is 99.3% effective. The client must be aware that although reversals have been done, these methods should only be considered if permanent contraception is desired. A vasectomy for men, and we'll start kind of like from the bottom of this little chart here, will take about only 15 to 20 minutes and is done under local anesthesia in the doctor's office. The client should be able to use ice packs and rest with minimal activity for about 48 hours afterwards. They need to report any fevers higher than 100.4, if they have any excessive pain, difficulty with elimination. They could have nausea, vomiting, redness, swelling, bruising, drainage, or incision edges that are not closed. If they have any of those, they need to report it to their physician. Patient does need to know that he is not technically sterile for at least 4 to 6 weeks. for somewhere between 6 to 36 ejaculations. They should have semen analysis done to verify sterility and be checked again and in about 6 to 12 months to make sure that that sterility is being maintained. With a vasectomy, as you see, they just actually kind of like tie off and cut the vas deferens, which is what carries the sperm into the epididymis and to send it through with the semen. So they still are able to ejaculate semen, but they just the semen doesn't have any sperm in it, which are the ones that come from the testes. Thus the saying they're shooting blanks, because the semen does not contain any sperm in it. A tubal ligation for females does take about 30 minutes under general or local anesthesia, but it involves an abdominal incision. Most women will have no long-term side effects, but they should know that there is a possibility that they may experience symptoms known as post-tubal ligation syndrome, that is said to include increased cramping and menstrual flow and non-cyclic pain. It is currently being done most commonly about 6 weeks after delivery to improve the effectiveness due to a decreased risk of tubal reanastomosis. There is a non-surgical method available, and that is called Essure. And this Essure is, again, non-surgical, non-hormonal. It does provide permanent birth control. It is about 99% effective. It has several advantages over a tubal ligation, and that is that there's no general anesthesia that's involved. There's no incision that's involved as well. Thus, this increases its safety, it lowers cost, and improves access to sterilization. With the Essure, a tiny coil is introduced and released into the fallopian tubes through the cervix. This coil promotes tissue growth in the tube, and over a 3-month period, the growth will block the tubes. So procedures uses a histoscopy under local anesthesia in the office. Since sterilization does not occur immediately after the procedure, women do need to be educated to use a second form of birth control for about 3 months until permanent tubal occlusion is verified, and is usually either verified by a histosalpingogram, which is your test to be able to determine for tubal patency, or sometimes an ultrasound can be done as well. Okay, so now that we've discussed the different types of family planning options that the patient or the couple has, now we need to discuss the role of the nurse in managing family planning. And the role of the nurse in family planning is to be able to assist the clients with reproductive decision making so that the clients have control over when to have their children. In making contraceptive choices, couples must balance their sexual lives, their reproductive goals, and each partner's health and safety. So we need to look at their decision considerations. So what do they use to be able to make decisions as to what method they're going to use? So they need to have the knowledge of contraceptive effectiveness to be able to make informed choices. And this is crucial for them to be able to make these informed choices. So, considerations that influence the patient's choice are going to include motivation, cost, cultural and religious beliefs, convenience, effectiveness, possible side effects, the desire to have children in the future, safety of the method itself, and comfort level with their sexuality, how comfortable they are using certain methods, if they're looking for protection from STIs, and how these methods will interfere with their spontaneity. So these are all things that they need to use to be able to consider when they're making their choices. Now, as part of their nursing role, the nursing assessment has to also be included in that. And so nurses can assist in this process by performing a complete health history and physical exam, by educating the woman and her partner about necessary labs and diagnostic tests that are required. You want to do, when you're doing your history and physical, you want to have specific areas of focus. And the one area will include medical history, like smoking status, cancer of the reproductive tract, diabetes, migraines, if they have hypertension, if they've had thromboembolic disorders, whatever allergies they might have, risk factors for cardiovascular disease. All of these are going to fall under the medical history. Under family history, we want to look into if anyone in their family has had cancer or has had cerebral vascular disease, like they've had a stroke or have some other neuropathies. Do they have hypertension? Do they have they've had coronary artery disease or cardiovascular disease? And if they have diabetes. So under their OBGYN history, things that we need to consider are going to include menstrual disorders, current contraceptive, what are they using now, previous STIs in the past, whether they've had pelvic inflammatory disease in the past or not, if they've had any types of vaginitis with specific methods or not, and what is their current sexual activity, what are they used to, what are they, how spontaneous do they want to be or need to be. Those kind of things are also going to be areas of focus as well. As part of personal history, you might want to include questions like, do they use tampons or other female hygiene products? What are their plans for childbearing in general, or do they have any children, or have they had children, and this is just contraception for preventing any further children? What's their comfort level for touching themselves? Putting something inside their vagina. How comfortable are they checking themselves in their private and reproductive areas? What's the number of sexual partners that they've had and their involvement in their decisions? So do they have a current partner that's very involved in their decision for childbearing, or are they even considering their partners while making this decision at all? Another area, again, of focus should be doing a physical exam on these patients. So you want a baseline, always wanting a baseline information. So height, weight, blood pressure, doing a breast exam, doing a thyroid palpation, pelvic exam. All of those are going to be important to be able to kind of have a baseline information for. And then lastly, diagnostic testing. So we might want to run some tests before we start them on a specific method And that might be a urinalysis, a complete blood count, doing a pap smear, checking for any STIs, so like vaginal culture or wet mount for an STI, doing HIV or AIDS testing, doing lipid profiles and what their risk for cardiovascular disease could be, and a glucose level. So, what are their risk of getting diabetes or having diabetes? Could be also detected from these. So, these are all things that as nurses, this is our part of what we can do as nurses to be able to help the patients make this informed consent or this informed decision on which method to use. We also have to consider education. So, if a contraceptive is to be effective, the woman must be able to understand how it works, must be able to use it correctly and consistently, and must be comfortable and confident with it as a method. So, this is the only way that the method is going to be effective for this patient. So, nurses can educate the client about which methods are available and their advantages and disadvantages, their efficacy, their cost, and their safety. Once the method is selected, then the client should feel satisfied with their choice and they should feel confident about using it. So they should leave the office or the clinic with knowing how to use the method, that they're going to use it correctly, and that the method will be effective for them. Ultimately, we can evaluate the success of the method by the lack of unwanted pregnancy. So when we have them come back in 3 months to reevaluate the method, then if they haven't gotten pregnant within those 3 months, then we know the method has been successful for them. We could do further investigation and see if they have any side effects that are unwanted or intolerable. But for the most part, we can really evaluate the success of the method by the lack of pregnancy while they're using the method. So there is an acronym, and that acronym is called BRAIDED, and that's BRAIDED. And this acronym covers all of the elements of an informed consent, all of which is within the responsibility of the nurse as part of the patient's care when dealing with family planning. And BRAIDED stands for B is for benefits. So we need to be able to, as the nurse, make sure that the patient is able to understand the benefits of the of using this method, giving her information about its advantages and the success rates that the method has had. The R stands for risk, and we need to be able to inform them about any disadvantages and any failure rates that the method may have had. A is for alternatives, so we want to be able to provide information regarding any other available methods that the patient may be able to choose from. So you don't want to leave the patient with only one method to choose from. I stands for inquiries, and inquiries are going to be having the patient, allowing the patient an opportunity to be able to ask questions regarding the methods that we're ultimately having her choose from. D is for decisions, and we want to give her the opportunity to decide which method is right for her, or to even change her mind on what method she might use. So we might start off with one method this time that she came. When we reevaluate it in 3 months, she might say, you know what, I really didn't like it, and I want to change to this method, or I want to try another method. And so we have to be able to allow her that opportunity. E is for explanations, and so we want to give her information about the method that she's chosen and exactly how to use it, so that she has the opportunity to be successful with that method, because she knows exactly how to use the method. And then D again is for documentation. So again, giving her information and documenting that the information was given and that the client understands the information that we gave her. And so all of these are the role of the nurse in being able to have patients manage their contraceptive choices. So now we're going to watch a short video on a summary of all the different methods that we just discussed on contraception.
In this video, we're going to run through all the main methods of contraception, which is basically any artificial method that people use to prevent pregnancy. The aim is that you'll understand how they all work, and can also discuss the pros and cons of each. First though, I just wanted to very quickly recap how pregnancy starts, which isn't in your course, but I think it helps a lot to understand contraception. This here is a picture of the female reproductive system. As we saw in the last video, the hormone FSH stimulates an egg in one of the ovaries to develop, and then after about 2 weeks, the hormone LH triggers the release of that egg, which we call ovulation. It then passes along the adjacent fallopian tube, and at this point it could combine with a sperm cell to form a fertilized egg. If it did, then this fertilized egg would continue along the fallopian tube to the uterus, where it would implant into the wall and slowly develop into a fetus. For reference later on, this part here is the cervix, which is the entrance to the uterus. So as we go through this video and look at all the different methods of contraception, keep thinking back to this process, and remember that contraception has to somehow interrupt this process in order to prevent pregnancy. One way to categorize all the different methods of contraception is to split them between those that use hormones and those that don't. The hormonal methods rely on releasing estrogen, progesterone, or some combination of the two. If estrogen is released steadily every day, then it inhibits the production of FSH. And as FSH normally stimulates egg development, it means that no egg will develop or be released. Meanwhile, progesterone stimulates the production of thick mucus in the cervix, which remember is the entrance to the uterus, and so prevents the sperm from ever reaching the egg. One of the most common contraceptives is the combined oral contraceptive pill, which contains a combination of both estrogen and progesterone, and is often just called the pill. It's over 99% effective at preventing pregnancy, as long as the pills are taken properly. But it can sometimes have side effects, such as headaches or nausea. There's also a progesterone-only pill, which is just as effective, but tends to have fewer side effects. As well as taking a pill, there's also a few other methods of slowly releasing hormones. The contraceptive patch is like a small sticker that you place on the upper arm, which slowly releases estrogen and progesterone, and each patch lasts 1 week. The contraceptive injection is an injection of progesterone into the upper arm, with each dose lasting 2 to 3 months. A longer option is the contraceptive implant, which involves a small device being placed under the skin of the arm, which will then slowly release progesterone for up to 3 years. Lastly, there's the intrauterine device, or IUD, which is placed inside the uterus. The plastic version releases progesterone, which remember will stimulate the production of a thick mucus in the cervix. There's also a copper version of the IUD, but it doesn't involve any hormones. It just prevents sperm from surviving in the uterus by killing them. So even though we've included it on this page of hormonal contraceptives, do remember that the copper IUD, which is sometimes called the copper coil, isn't a hormonal contraceptive. And whether you look at a plastic or the copper IUD, both of these can last over 3 years. So as you can see, there are loads of different types of hormonal contraceptives, and they all work in a pretty similar way. The big difference is how invasive the initial treatment is. For example, taking a pill versus having something implanted into your body, and how long they last, which varies from days to years. Our second group of contraceptives was the non-hormonal methods. What these have in common is that they all work by somehow preventing the sperm from meeting the egg. For example, condoms are worn over the penis, which traps any sperm. There are also female condoms, which are worn inside the vagina, but do basically the same thing. One of the important things about condoms is that they're the only form of contraception that also protect against sexually transmitted diseases, or STDs. Next, there's the diaphragm, which is a shallow plastic cup that fits over the cervix to block sperm from entering the uterus. Unfortunately, it's not that reliable though, so it has to be used with spermicide, which is a substance that kills sperm. Spermicides can be used alone as a form of contraception, but they only work around 7 out of 10 times, so they're not really that good. Now, a more drastic method is sterilization. In women, this involves cutting or tying the fallopian tubes, which remember connect the ovaries to the uterus. And so if they're cut, the eggs won't be able to pass from the ovaries into the uterus anymore. This is pretty much permanent though, so it's generally only chosen once a woman has had all the kids that she wants. Men can also undergo sterilization by having their sperm ducts cut and tied. Sometimes people use so-called natural methods, such as only having sex at certain times of the month, or stopping sex just before ejaculation. These are both very unreliable though, and not recommended. Of course, the only way to be 100% sure of avoiding pregnancy is by abstaining from sex altogether.
Okay, well, now that we've discussed infertility and family planning, we are going to discuss abortion. And the definition of abortion is defined as the expulsion of an embryo or fetus before it is viable. The purpose of abortion is to terminate a pregnancy. More than 40% of all women will end a pregnancy by abortion at some time in their reproductive lives. Roe versus Wade was a Supreme Court decision that was meant to have easy and legal access to pregnancy termination. Roe versus Wade was a federal Supreme Court decision, and this federally mandated that it was legal to perform abortions, while the states will determine the resources and the access. And today, we've had very controversial abortion laws be passed recently, as well as abortion always being a very political and controversial topic to discuss. But we're going to discuss the medical and aspects of abortion, and we're going to discuss certain things. We're going to discuss the types of abortion, which you have surgical and medical. With a surgical abortion, there are 2 types of different surgical abortions that could be done. You have a vacuum aspiration, and you have what they call a dilation and evacuation, or a DNC. The method that they will use under a surgical abortion is based on the gestational age of the fetus. It is an ambulatory procedure that's done under local anesthesia. The cervix is dilated, and the products of conception are removed by suction evacuation. The procedure is rather quick. It takes about 10 minutes. Overall risk for complications is less than 1%. The major risk, if done in the first trimester, are infection, uterine perforation, retained products, and cervical tear. The second type is a medical abortion, and the medical abortion is achieved through the administration of medication. The route is vaginally or orally. The medication is given in the office, and it may require about 2 to 4 visits depending on the gestational age. The cost of a medical abortion is usually somewhere between $300 and $800 because of the costs of the medications. There are currently 3 different drugs being used. In the first trimester, which we'll discuss later as we go through antepartum, is before 12 weeks of gestational age. The first drug that is used is called methotrexate, and this is an anti-neoplastic agent, and followed by the misoprostol, which is a prostaglandin agent, and this is given vaginally or orally 3 to 7 days later. The second drug that's used is mifepristone, which is a progesterone antagonist, which is followed by the misoprostol, again, which is a prostaglandin agent, 48 hours later. And for testing purposes, the only thing that you're going to need to know is that there are medical abortions done. You just need to know the 3 current drugs that are being used, what class that they're in, whether it's an anti-neoplastic or a prostaglandin agent, and when they're given. So for testing purposes, that's all you are required to know. Once these meds are given, or once a surgical abortion is done, we assess the patients prior to and after. Assessment should be done cautiously. It's a very sensitive topic. It's a very sensitive situation. It is essential to explore the woman's feelings about the pregnancy before consoling her or discussing her options. This is a very emotional and deep personal issue, so you must be able to provide support and accurate information each time we discuss or we talk to the patient. Nursing ethics really does play into abortions. So for religious or ethical reasons you feel unable to actively participate in the care of a woman undergoing an abortion, you still have the professional responsibility to ensure that the woman receives the nursing care and help that she requires. So most importantly is that if you know you are ethically and morally against abortion, or for religious reasons against abortion, then choosing to work in an environment that performs abortions may not be the job for you. And so that's where, when you're seeking employment, you're going to seek employment in a position that does not cause you to have to put your ethical and moral standards on the line every day. Nurses must keep in mind that all women have the right to have access to an unbiased and factual information about available reproductive health choices and whether they seek to end or start a pregnancy, so from which they can then make informed decisions about their own reproductive health. Okay, and so lastly, our last topic that we will cover today is violence and abuse. Gender-based violence is a major global public health and human rights problem, and one that often goes unrecognized and unreported. Imagine if you were subjected to assault, rape, sexual slavery, torture, verbal abuse, mutilation, even murder, all because of your gender. It is a common source of physical, psychological, and emotional morbidity. It occurs in all countries, irrespective of social, economic, religious, or cultural groups. It affects women across race, ethnicity, age, socioeconomic status, religion, sexual orientation, and geographic boundaries. Due to the unequal power relations between men and women, women are violated either in the family, in the community, or in the country in which they live. The causes are multidimensional and are social, economic, cultural, political, and religious. The types of gender-based violence are going to include intimate partner violence, sexual abuse, female genital cutting, and human trafficking. We'll start with intimate partner violence. This is actual or threatened physical or social violence or psychological or emotional abuse. An intimate partner individual includes those that are currently in dating, cohabitating, or marital relationships, or those who have been in such a relationship in the past. According to the Federal Bureau of Investigation, in 2015, up to half of all women in the United States will experience some form of physical violence during their lifetime. In North America, 40 to 60% of murders of women are committed by intimate partners. Because a nurse may be the first healthcare provider to assess and identify the signs of intimate partner violence, a nurse can have a profound impact on the woman's decision to seek help. Thus, it is important for nurses to be able to identify abuse and to aid the victim as much as possible. Sexual abuse, one of the other gender-based violence, includes nearly 4 out of 10 women and 1 out of 10 men in the United States have experienced rape, physical violence, and or stalking by a partner with intimate partner relations related impact. Intimate partner violence related impact. The FBI actually had to change their definition of sexual abuse on their website in order to include new types of violence that was being detected and found and trialed in courts and were being let go or not prosecuted because of the narrowness of the FBI definition. So now the definition actually had to be rewritten in order to be broader as a definition. So the new FBI definition on the FBI website includes penetration, no matter how slight, of the vagina or anus with any body part or object, or oral penetration by a sex organ of another person without the consent of the victim. And so this is now currently the new definition of sexual abuse. This broader definition will have a dramatic impact on the way that rape is actually tracked and reported nationwide now. The third gender-based violence that we're going to cover is female genital cutting. This is aka the female genital mutilation or female circumcision, defined as a procedure involving any injury of the external female genitalia for cultural or non-therapeutic reasons. The international community views this practice as a human rights violation. It is a surgical removal of a portion or portions of the genitals of the female infant, girl, or woman. It includes the clitoris, which is type 1, the clitoris and the labia minora, which is type 2, the clitoris, labia minora, labia majora, and then suturing of the remaining tissue, known as fibulation, to leave only a small opening for urination, menstruation, intercourse, and childbirth is type 3, and there is a type 4 which encompasses all of the other mutilations of the female genital area, such as pricking, piercing, cutting, cauterizing, and scraping of the vaginal tissue, incisions to the clitoris and the vagina, and burning, scarring, or cauterizing of tissue with the aim of tightening or narrowing the vagina. Female genital cutting is a worldwide practice that affects millions of women and girls. According to the World Health Organization, in 2015, UNICEF, 140 million women are victims of female genital cutting, with about 130 million girls between infancy and age 15 undergoing female genital cutting every year. Complications vary depending on the type of cutting and the way it was performed. It is frequently performed without anesthesia under non-sterile conditions. Cutting tools can be anything from razors, knives, to pieces of glass or tin, the tin can, the lids of the tin cans can also be used. Complications that these women can suffer from is infertility, dysmenorrhea, which is painful periods, dyspareunia, meaning painful intercourse, sexual dysfunction, infection. They could hemorrhage after the procedure. They could have vaginal stenosis, chronic vaginitis. It could cause them to have pelvic inflammatory disease, chronic urinary tract infections. They can suffer from incontinence, genital fistulas. They could have transmission of HIV and hepatitis during the procedure. They could have severe pain and shock after the procedure. They could have difficulty walking or using the stairs due to the severe scarring. They could have urinary retention, and they could have an inability to experience orgasm or difficulty even giving birth. As immigration to the United States increases, nurses are increasingly likely to encounter women affected by FGC, female genital cutting, and its complications. And then lastly, we're going to speak a little bit about human trafficking. In the United States, in the United Nations, it defines human trafficking as the recruitment, transportation, transfer, harboring, or receipt of persons by means of the threat or use of force, of abduction, of fraud, or deception to achieve the consent of a person having control over another person for the purpose of exploitation. Within our borders, thousands of foreign nationals and U.S. citizens, many of them children, are forced or coerced into sex work or various forms of labor every year. The United States is a major receiver of trafficked persons. Human trafficking is a modern form of slavery that affects nearly 1 million people worldwide and approximately 20,000 persons in the United States annually. Women and children are the primary victims of human trafficking, many in the sex trade as described above, and others through forced labor, domestic servitude. Trafficking persons is hugely profitable. One estimate places global profits at approximately $35 billion annually. Victims are primarily, of course, women and children who lack education, employment, and any economic opportunities in their own countries. Traffickers promise these victims employment as nannies, maids, dancers, factory workers, sales clerks, or even models in the United States. Traffickers will transport the victims from their countries to unfamiliar destinations away from all of their support systems. And once they are here, the traffickers coerce them using rape, torture, starvation, imprisonment, threats, or physical force into prostitution, pornography, the sex trade, forced labor, or involuntary servitude. Although no one sign can demonstrate with certainty when someone is being trafficked, clinicians should be aware of several indicators. It is important to be alert for trafficked victims in any setting and in order to be able to recognize these cues. On page 288 in your book, on box 9.6, there is a lot of information on the cues that you would be able to pick up, which might alert us as clinicians to be able to know if someone is being trafficked. The nurse's role is major in assessing women who have suffered some type of violence. Nurses have a central ethic of caring and an agenda of early intervention and health promotion for their clients to be able to improve their health status and well-being. As a professional nurse, the act of screening women seen in every healthcare setting is often the very first step for a victim to start thinking about a better future. So remember, your words carry weight with your client, who looks to you for help, support, and encouragement. And that is the end of our lecture today. Please be sure to ask your instructors any questions. Refer to the discussion posts for your questions or interactive discussions. And I hope you enjoyed the lecture, and we will continue our OB information. See you next time. Thank you.